So what is VMA? VMA is vertebral motion analysis. It's a way for us to look at the spine in patients that suffered an injury. It's controlled. Very important. We control the motion of the patient in the machine when we acquire the image. That control allows us to have repeated imaging that is consistent and reproducible compared to other studies such as just simple flexion and extension. Some of the other companies out there will say that they can reproduce the study. This is absolute reproducible. Do the same patient twice or 3 times the same day, you're going to get the same numbers. It's reduced radiation because we use special pulsed fluoroscopy. It's less total radiation for the patient. You know, they've probably been imaged before and now they're getting imaged again, and the concern is, should we give them more radiation? Actually, we're giving them very limited radiation because of the technology that we use for VMA. We can use classic flexion and extension comparison studies they've had previously. In so doing, we can see if there's been a significant change between the original X-ray and what we're acquiring today. If the patient's had multiple injuries, again, we can use all of those X-rays in comparison to render a diagnosis that's going to benefit the patient long term. We have data supporting this, studies from 2013 and 2021 that talk about the sensitivity and specificity of VMA and how it's very significant in taking care of patients. It's dynamic, okay? X-ray can be static. MRI is static. But this is dynamic. We look at motion, we look at function. We can see pathology because we see the pathology in motion. Patients don't live static lives. They don't live lying down on an MRI table. Although MRI is very sensitive to pathology, and we can see pathologic ligaments and tendons and facet joints and abnormal fluid, with VMA we are allowed to see the pathology because of the motion and abnormal vertebral translation, one vertebral body relative to the other. And again, we can see every level versus just generalized flexion and extension abnormalities. So how is VMA different than what you're already ordering or what you're already seeing reports on your patients? It's motion. X-ray and MRI is not. It detects ligamentous instability or stability. But we see instability every day with the VMA studies. We rarely see that on MRI. We can do flexion extension. We can't with MRI. Sometimes we try to put the patient in flexion and extension by putting bolsters behind the shoulders, but those images are truly never diagnostic, and there's motion inherent in that. It adheres to the AMA guidelines. VMA does, and X-ray and MRI don't. Its challenge is inconclusive when you go to a legal case because it's subjective, X-ray and MRI, because they'll argue that it's an old study, it's an old injury, there's degenerative disc disease. But with VMA, we can evaluate the stability and or instability of the spine that we can't detect. And if we have an old study, preferably, we can show that there's been a difference since the injury. And for in-office, it's reimbursable, it's got high value. Typically, X-rays and MRIs are outsourced. So the literature is quite remarkable with VMA. Once people started studying it, they realized how significant it was. Its sensitivity and specificity are 41.2% to 44.6% increase in sensitivity for spine injury compared to X-ray and MRI. And the translation, we can determine whether there's 0.1 or 0.5 or 0.7 millimeter translation, and we look at each level, which then we can hand to the treating physician so he or she can say, that is a significant abnormality, and it's at the level that I'm concerned with based on a dermatome pattern or how the patient's manifesting their injury. So concisely stating, we improve diagnostic accuracy as it pertains to spinal injuries. It's quantitative, it's repeatable, it detects very subtle abnormalities that, again, MRI may not show. And it's the differentiation in determining, is there a pain generator at this level or that level? Is it the facet disease? What is it? Is it the disc disease? So we put all the studies together, and with the benefit of VMA, we can have a more honed-in view and descriptor of the pain generator. We do personalized interventions. Based on the VMA, the surgeon or neurologist can direct their treatment specifically to a certain area or a certain portion of the spine, be it the facet joint, disc disease, or the ligaments. The surgical decision making is made easy for the surgeon. They've got a lot more information. so they can benefit from that when they plan their surgery. And most importantly, post-surgical, they can evaluate the same study, do another VMA, and see that their stabilization, their fusion is stable. Because we know some patients suffer the old dreaded failed back syndrome. The reality is a lot of those aren't failed backs. There's ligamentous instability at other levels as well. They've treated one level, but there's actually other levels that are now manifest on VMA that we didn't appreciate prior. And it supports the therapy they're getting with their chiropractors. It also shows monitoring progression and improvement in the patient's mobility and ability to flex and extend and live a life, lateral bending. Once they've been stabilized, once they've been treated appropriately, the patients benefit from this. So it's quantifiable, research applies to it, early detection, we're not invading the patient, there's no needle, and we educate the patients and make them aware of this is another tool that we can use in evaluating them and then therefore setting up treatment and following up their treatment to make sure that they live a more healthy and happier life. Thank you for your attention.